All right, so this month we have respiratory, not very long. It's a nice, quick, easy one for us. Brian Melville, who is the Director of Education at Superior Ambulance, has put this one together. I will tell you, he loves SpongeBob. I have no idea where he got a lot of the slides to go along with it, but it's very cheerful, I guess is the best way. We're going to go ahead and talk about ventilation and respiration pathophysiology a little bit. We'll talk about our SOPs and medications that we administer. And we are not doing a skills review this month. So I'm just going to go ahead and put up all the stuff on there. Talking about the upper airway. Now, our upper airway is obviously where oxygen will go ahead and enter. And it will either pass through the mouth or the nose. The nares, it goes through the terminates and the cilia, go ahead and humidify and cleanse some of that air before it makes its way down into the lungs. You have obviously the mouth. Tongue is the area where it is most commonly the cause of sometimes airway obstructions. Unless we're just talking about someone maybe sleeping on their back, that tongue drops down. You've got someone who's unconscious on the floor, their tongue will drop in the back of the throat. It's a very simple fix with a manual airway or opening the airway. Tonsils and adenoids are back in the nasopharynx. Now, for most adults, their tonsils are gone, their adenoids are gone. But in our pediatric patients, a lot of times we see enlarged tonsils, and sometimes if they get a cold, they get the flu, strep throat, those tonsils can become even more swollen and can make breathing very difficult. We have the vallecula. The vallecula is the area that we go ahead and insert the Macintosh blade in when we get ready to intubate. Helps pull up that epiglottis so that we can pass the tube through the cords. Epiglottis, flappy piece of skin that basically protects the tracheal opening, the glottic opening. In this area, we can actually have it become swollen. It can be damaged from superheated air, anaphylaxis. Areas where we have laryngospasms can cause difficulty breathing in that area. When we also look here, the only other membrane or the area that's really important is the cricothyroid membrane, because that is the area that if we cannot go ahead and get an airway with either our King tube, our ET tube, we always have the option to do a quick trach in our system, otherwise a surgical trach, based on what your protocols are. But that cricothyroid membrane is the area that you would go ahead and insert that needle and tube into. Now, with our pediatric patients, they're not just little adults. We know that our ped structures are different. Yes, they're smaller for one. The heads are a little bit larger on pediatric patients than from adults. They're, like their nares are smaller openings, and their tongues are larger, so they have a time that they can have an obstructed airway. Their adenoids, their tonsils have a tendency to be a little bit bigger. The epiglottis is floppy, so it's sometimes making intubate pretty difficult. They have a greater chance of having vagal stimulation, meaning that when we go to intubate them, we can stimulate that vagus nerve and drop down that heart rate. We actually took out of our protocols the atropine that we used to give prophylactically to go ahead and prevent that. Remember also that their airway is like a funnel. With us, the glottic area is the is the narrowest or smallest part of the airway. But in pediatrics, it's the cricoid area that's the smallest part. So we move down to the lower airway. The lower airway is comprised of mainly the trachea, breaks off into the bronchi, bronchioles, and then all the way down to the alveoli. And remember our trachea, that's got those nice C-shaped rings that keep the airway pretty stable, can keep it open. You've got the point of the carina, which is where they separate off. And if you actually take a look here, you can see how much straighter this right main stem is compared to the left, which is why it's not uncommon when you intubate, if you insert the tube too far, that you go right down into the main right stem. So you always want to make sure that you do that, you deflate the pilot balloon and then go ahead and pull the tube back. So what stimulates us to go ahead and breathe? Well, our respiratory drive mainly comes from the medulla oblongata, okay? It's the chemoreceptors within our body and the baroreceptors within our body that will help us stimulate to breathe. Now, for most people, it is the carbon dioxide, well, it's the pH in the blood, but the carbon dioxide can indicate whether or not we need to go ahead and breathe. And we see those usually in the aortic arch a lot of times. Normal pH is 7.35 to 7.45. And then we talk about our partial pressures of oxygen, 80 to 100%. Now that's pretty standard. When we do blood gases, that's kind of the number we're looking for. But if we're over-oxygenating a patient, sometimes those numbers can be 3, 4, even higher if necessary. When you have patients who suffer from like COPD, some type of obstructive disease, they have normally high CO2 readings. And so they're being stimulated to breathe based on oxygen levels. Which is why they always used to tell you, don't ever put oxygen, high flow oxygen on a COPD patient. We know that to be false. I mean, by the time we would give someone 15 liters by non-rebreather, the ER would have to do it, and it would almost be the ICU's problem by the time we would maybe knock out that hypoxic drive in some patients. Now, when we go ahead and breathe, our diaphragm pulls down, and that's the active part of breathing. It allows us to go ahead and expand our lung, makes kind of a negative pressure so that oxygen will go ahead and rush in. We've got the phloritic nerve, that's what's going to control that diaphragm. Now we have the Hering-Brewer reflex, which is what doesn't allow us to overinflate or overexpand our lungs. And so it's got that, from the stretch receptors, it'll say, okay, that's enough, no more oxygen can go in or no more air can go in, stop breathing. The passive form of breathing is our exhalation. The diaphragm basically goes ahead and relaxes. And then air will rush out. When we start talking about ventilation versus respirations, this always kind of blows my mind because we always go, well, what's a respiratory rate? To be very honest with you, we cannot determine someone's respiratory rate if you're using proper terminology. Respiration is the act of gas exchange down at the level of the alveoli and the alveolar capillaries. So that's not something we can visually see. What we can see is the mechanical form of breathing, and that is ventilation. And so we can count someone's ventilatory rate. We can't count someone's respiratory rate. In order for a patient to really go ahead and keep that homeostasis within the body, you have to have the ventilation and the perfusion working together. The VQ, we can't have what we call a VQ mismatch. A lot of people have been asking me, ventilation perfusion mismatch, why Q for perfusion? It was based on a bunch of pulmonologists that just decided to use Q as their symbol for pulmonology, so that's really, there's no big earth-shattering reason why it's a Q. It was just that's what they chose for their symbol. But when we talk about VQ mismatch or ventilation perfusion mismatch, you have to have the proper tidal volume, the proper ventilatory rate for a patient. Then you have to have the proper perfusion, blood circulating through those alveolar capillaries to go ahead and offload CO2 and unload oxygen to take it to the rest of the tissue. Any deviation from that will go ahead and cause problems within the body, will cause tissue not to receive the oxygen it needs, cause the brain not to receive the oxygen that it needs. So for example, you have someone who's breathing very shallow. They may be breathing 12 times a minute, which you're sitting thinking, oh, respirations are 12 times a minute, they're doing fine, but they're breathing really shallow. Remember, the first 150 cc's of air a person breathes is from dead airspace. And so no gas exchange actually occurs in those areas. And if they're breathing shallow, that's the only air they're really moving. They're not getting deep down to the alveoli where gas exchange truly occurs. So their ventilatory status is not going to be good enough. Their perfusion, their blood flow may be just fine, but the oxygen is not getting to those end organs. Other things that might go ahead and cause a VQ mismatch: atelectasis, collapse of the alveoli. Gas exchange cannot go ahead and occur in alveoli that are collapsed. Gas exchange cannot occur if we have someone with pneumonia or some type of infection around the alveoli. They have that empyema that is prohibiting gas exchange from occurring. And so that will cause a VQ mismatch. You might have someone who has a pulmonary emboli, where blood flow is actually shunted away from those alveoli. Someone who is hypovolemic or anemic in itself, where we don't have enough hemoglobin to go ahead and carry the oxygen necessary. So there's a lot of different things that can cause that VQ mismatch in a patient and allow for adequate breathing. So when we start off and we take a look at a patient who has the claim of difficulty breathing, the first thing we want to do obviously is inspect our patient. Take a look at them. What color are they? Are they dusky color? Are they pale? Are they getting good blood flow, good circulation, good oxygenation? Do we see retractions, intercostal muscles being used in order to go ahead and assist in ventilations? Do we see the mucosal membranes being dry, the lips being a cyanotic type of color? When we look at their ventilatory rate, what is the pattern that we're actually seeing? Are they doing this deep, fast, rapid breathing that we call Kussmaul respirations? If so, maybe they have DKA. It's a sign that the body is metabolically acidotic, and we're trying to go ahead and blow off some of that acid, make ourselves respiratory alkalotic to kind of reverse that a little bit. Or do we have someone maybe who has a head injury, has that BS, the neurological pattern, where they breathe really erratic. They're fast, deep, and then they go down to very shallow, then fast, deep, and go back to shallow. So take a look at the respiratory patterns, see what you're seeing, and how effective is their breathing. Next thing we want to do, if we have a patient that we know that we may have to intubate, when we're reviewing the protocols, if you take a look at our drug-assisted intubation protocol, it says, attempt intubation ×1, if unsuccessful, move on to our rescue airway. That really kind of bothers me a little bit. I understand ET tube or ET intubation is our golden standard for airway placement, but if someone is not successful, if someone's skill is not up to par, or it's a difficult airway, then the patient doesn't get oxygen. No oxygen, no patient. No airway, no patient. So we want to make sure, are we having problems?
No.
With it? Okay. I didn't know if it shut off or something.
No, you're good.
So we want to make sure that we're assessing our airway and doing what's best for the patient. You know, if you haven't intubated someone in a couple of years, and you have someone that's got a difficult airway, your choice may be the king. Not because, you know, you're not good enough, but it's just a difficult airway. And so honestly, I believe that's the way the protocol should be written. And currently we can do it now. So this is our Malin potty score on the top. Class 1, they open their mouth, you can see everything. You can see the hard palate, the soft palate, the uvula. But if you look at class 4 here, you're only seeing that hard palate. You can't see it. That person's going to be rather difficult to intubate. So as you're doing your assessment, you're like, I think I'm going to go ahead and use the king instead. And if that's the case, just document it. Based on assessment of airway, patient having a difficult airway chose the king tube instead. Patient gets airway or air a lot sooner than if you're dinking around trying to get that tube. But it's always a good idea to make sure that you're assessing that airway for its difficulty. Listen to lung sounds. And listening to lung sounds isn't a quick 1, 2, 3, 4 over their winter jacket. You actually have to put your stethoscope up against the patient's skin to get a good lung sound. I know, but you can always decon your stethoscope when you're done. But listen to what lung sounds. Someone's got stridor. Usually the upper airway might indicate some type of obstruction, whether it's swelling, whether it's a foreign body. You can go ahead and make that determination. How about if someone's wheezing? Where are they wheezing? Is it inspiratory wheezes? Is it expiratory wheezes? Is it someone who has asthma and I can't hear anything in the bases, but I hear wheezes up above? Are they starting to clamp down? How critical is my patient? Do they have rales? Is it in the bases? And that's normally where we do hear rales. Fluid in the lungs for whatever reason. Maybe the bronchi, they've got bronchitis. It's in those larger airways and it sounds like a bunch of mucus. As far as palpation, you know, it's always a good idea to put your hands on someone's chest if you're having problems identifying if they got good lung expansion. Let them take a deep breath. Does the chest move symmetrically? Good rise and fall, equal bilaterally. You can go ahead and do a blood pressure by a manual blood pressure. Listen, do you have a change in what your blood pressure is when they inhale and when they exhale? Currently, right now, we use the pulse oximetry. We use the number 94. I will tell you there is a change coming up because American Heart has dropped that number down to 90 for pulse oximetry readings. So that will be coming out in our new protocols. Currently, if someone has a pulse ox at 94 or greater with no respiratory distress, we don't give them oxygen. If someone's sitting at 91 and 293 with respiratory shortness of breath, we might start them with oxygen at 2 liters by nasal cannula and titrate as necessary. Remember, you can change that by changing your FiO2 or the concentration of oxygen. If you if you're using a nasal cannula at 2 liters, you're really only giving them about 22 to 24% oxygen. When we inhale, they're getting 21%. So it's not a big change by bumping that up a little bit, but it can make a difference on their pulse oximetry. Obviously, when we get down to lower numbers, you may have to go ahead and choose to either intubate or use CPAP or a non-rebreather. But remember, now when you guys put your patients on pulse oximetry, does your monitor show the breadth of your pulse ox? No, it does not. You don't have it set up that way? Okay. It is a good way that you can make the determination if your pulse ox is truly working appropriately. You know, a lot of people say, oh, pulse ox is, 89%, and you look at the patient, they're pink, warm, and dry, they're mentating just fine, and something may be wrong with it. And that's just because there's so many negative positive results on it that can affect it. You know, looking at that pleth to see, do you have a good pattern going along with it? If you don't, does your pulse match what you're seeing on your monitor? If it doesn't, then your pulse oximetry is probably not adequately reading. But there's a lot of different things that can affect it. You've got your elderly patients and their hands are cold to the touch. That could affect it. I know most of them now, the fingernail polish isn't such a big deal as what it was years ago. They've gotten a little bit better. Maybe someone's anemic. There's not as many hemoglobin. And so they may be saying they're 100% because the hemoglobin that are there do have 100% oxygen, but there's not enough hemoglobin carrying oxygen to get to those end organs. Same thing if they're hypovolemic, they're from hemorrhagic shock. You might be losing carbon dioxide or carbon monoxide. Remember, carbon monoxide has a 200 times more affinity to oxygen and are going to attach to those hemoglobin a lot faster. There's one quiz question, and it talks about the oxygen dissociation curve. You think back to paramedic school, and I know for some of you guys that was a long time, probably wasn't even taught to you, but we have what we call the oxygen dissociation curve, and it should be constantly changing, meaning that if it's shifting to the left, your lungs are going to be covered. You're doing good, but you're going to have a problem at the tissue. If that oxygen dissociation curve shifts to the right, more carbon dioxide is attaching to the globulin, and we're going to have a problem at the lungs, but the tissues are going to be perfusing like they should. So that only really comes into play when you start working with vents and understanding that a little bit more in depth. But for basic pre-hospital knowledge, not something we really need to brush up on. So how are we going to manage that patient's airway? Well, there's many different ways we can do it. We can start off with the very basics. Simple airway maneuvers to open the airway. Head tilt, jaw thrust, modified jaw thrust, if they have possibly a spinal cord injury. But just simply removing that tongue off the back of the throat, allowing that airway to go ahead and open up. You have a pediatric patient who's leaning up against the pillows on the couch and their heads kind of droop down because they're just so tired. And you hear these snoring type respirations. Simple just opening up or moving their head can make their breathing a little bit easier. We can go ahead and use the bag valve mask to ventilate our patients as needed. But anytime we're using the bag valve mask, we always want to make sure that we are using some type of airway adjunct, whether it's an oral or whether it's a nasal. Bag valve mask, as long as you're getting good chest rise and fall, it's good when you're sitting. Needs two people a lot of times to make sure you got that good seal, but bouncing down a road, not the best. It's always better to secure that airway if you're getting in the back of an ambulance, because you're going to end up with a stomach full of air. And what goes in must come out, and most of the time it's not going to be just air. You're going to have a slight mess on your hands. Anytime we're dealing with the airway, we want to make sure we have suction available to us. Take a look. Is there some foreign body airway obstruction? Do we need to get out a laryngoscope handle of McGill forceps? Can we pull that foreign body airway out, or foreign body out of the airway? And then open up that airway. Do we need simple suctioning? They've got blood in their airway. They've got a lot of mucus in their airway. Do we have the patient on a trach, or even the ET tube, that maybe there's a mucus plug at the end, and we would need to go ahead and suction? How do we go ahead and suction the trach or the ET tube if we're going to do some deep tracheal suctioning for these patients, because they've got some type of mucus plug or mucus in the way? So after we choose to ventilate our patient for 3 minutes, we can make the decision to go ahead and use our drug-assisted intubation if our patient still has a gag reflex. If they don't, obviously we don't need to go through all the medications that are out there. But the difference is, obviously, is that intubation is the best way to secure an airway. It separates, there's no chance of aspiration as long as you've done everything correctly. You're using the proper equipment, the proper tube size. But if you've got someone who is not as experienced intubating, it can take longer to get that airway. And then your patient's brain can end up becoming anoxic if you take too long. Or you go ahead and intubate the esophagus and you're not paying attention to what you're doing. We currently use different medications. So we'll start off by ventilating our patient for 3 minutes with the bag valve mask, getting them ready with pre-oxygenation while someone else is getting all the equipment ready, getting an IV established. We're going to go ahead and start with etomidate 0.3 milligrams per kilo to a max of 20. And that medication, remember, is a dissociative medication. It works very short time. So it's always a good idea to have everything ready to go. Have your patient or have your partner push the medication, count to 10, and then you can start your intubation process. Once you verify tubes in place, we need to make sure we're doing it in a couple different ways, and we'll do that on the next slide, and we'll talk about that a little bit more. But as soon as that's done and you've secured the tube, the next medication should be your Versed. Don't wait for the patient to start coming around and waking up a little bit. Go ahead and give them the 2 milligrams of Versed right away, every 2 minutes, and we can go to a max of 20 milligrams. Now, ketamine is another medication we've talked about using, has many different routes. We were all set to go ahead and add it into St. Francis's protocols, but then we found out obviously there was a shortage of ketamine, so that kind of blew that, but we were trying to move that way. Ketamine has many different things. You can use it for RSI, you can use it for behavioral patients, you can use it for pain management. Definitely needs some training on how to administer it, but it's a medication that seems to be working very well through other places that have been using it. You have your paralytics. your non-depolarizing and your depolarizing paralytics. Take, for example, succinylcholine is a depolarizing, meaning that it's depolarizing the muscles and it kind of keeps them there and paralyzes them. Doesn't allow them to go ahead and relax. Whereas the non-depolarizing doesn't allow them to go ahead and contract when you start talking about the different types. A lot of them very short acting. Have to make sure that you're good at intubation to be able to go ahead and use these medications. How long are we looking? Well, when we intubate, one thing that Dr. E wants us all start to do when we get ready to intubate, and that's putting a nasal cannula on a patient and turning it up to 15 liters. We're providing that oxygen washout in the back of the oral pharynx, in the nasal pharynx area, so that you do have a little bit longer to go ahead and perform that intubation. SATs don't drop, or their oxygen saturations don't drop as quickly when you go ahead and use the nasal cannula.
Quick question.
Yes, sir.
Would it be all right just to hold the bag valve mask further away from, like, kind of right in the area?
No, they want it right in the, they want it blowing really fast up into the nasal passages, so it's really concentrating in the back of the throat area.
So disconnect bag valve mask, hook up nasal cannula, intubate, re-hook it up?
Yeah, it's providing a much better opportunity. And if you're in the back of an ambulance, you got multiple oxygen ports. Or do you guys? I should say, before I answer that, do you guys? Yeah. Let's see here.
When you are talking 20 milligrams of Versed, that's if you have if you got the intubation, and or is that king tube then, would that be acceptable as well?
Yeah, if I have someone that's starting to wake up a little bit, and I've got the king tube, absolutely. 2 milligrams every 2 minutes. You can go up to a max of 20. Yeah.
But if you,
So if you miss the intubate, the
Right.
Versed is basically just to kind of keep them down.
right.
So whether you have a king tube or whether you have the ET tube in place, go ahead, absolutely, and use your Versed. Absolutely. Also, I was going to tell you, make sure that you do have your suction available so that if for some reason you need to suction that airway, you don't have to pull out your blade and get your suction out. You've got your blade in place, go ahead and suction right away, and then you can go ahead and intubate if necessary. And like I said, that oxygen washout really is a benefit to you guys because it allows you a little bit more time to intubate. How far are we going to go ahead and put the tube in? Making sure that it's not going into a right main stem. Listen to lung sounds. And then when we do this, we want to make sure that we confirm that we were successful in tube. Standard of care and the golden standard for confirmation is end tidal. You have to use that on everybody that you intubate. Put the king on. You can even use it on those that you're using the bag valve max, but the intubation is the main one that we're using for confirmation. You must document in your report. That is one of the ways you confirm tube placement. Then you should find one other method, so you always have 2 methods as what you're documenting. I saw the cord pass through, or the tube pass through the cords. There was misting in the tube. The esophageal detector, the one that kind of looks like the end of a turkey baster, you can go ahead and use that one. There's different ones that you can use to go ahead. Listen to lung sounds, but we always listen over the epigastric first, and then listen to your lung sounds. You don't want to put too much air in the stomach if it comes down to that. If you don't have end tidal, for whatever reason, we have the colorimetrics. The ones with the little litmus paper that were never all that great because the minute fluid touched them, they were kind of shot. And it took about 6 to 10 breaths to ventilate before you actually saw the colors start to change. And we looked at yellow is yes or golden is good. But if we ever saw purple, purple was a problem. And then we needed to go ahead and change our tubes. We're looking though for that capnography. Capnography has been such a great tool to go ahead and use in many different situations. Whether it's a patient who we're intubating and we're looking to see that we got really nice waveform. If we're seeing a straight line at that baseline, we're not in the right spot. Now, there has been some studies, few, that says if someone has had copious amounts of carbon dioxide, that may actually be detected. But there's only been a couple actual proven cases of that. Capnography also is really good for someone who's in DKA. You've got a patient and they've got a blood sugar of 400 or 500. You put the end tidal on them and you notice they have an end tidal of 25. You're able right then and there to say, yeah, they're DKA. They have metabolic acidosis building up within the body. The Kussmaul respirations are trying to change that to bring homeostasis back. We're looking for, kind of rapid hyperventilation. You might use it for someone who is septic. Remember, we're looking for lactate levels, and those levels, if they have a 4 or greater, we know that they're going to have an end tidal of about 22 to 25. It's great when you're doing CPR to tell you how good a CPR am I actually doing. We would ultimately like you guys to keep it about 22, but realistically that doesn't happen. If you guys are doing 22, great, you're doing awesome CPR. But anywhere above, the number seems to keep changing every time you read something new. But if you're keeping it above 15, you're doing good. You can tell if you have return to spontaneous circulation because all of a sudden it's going to skyrocket up into the 60s, 70s, if not higher. And sometimes when you're doing or working a code and you go to feel that pulse, you're like, I don't know if I feel it or not. You can see if you have return to spontaneous circulation on your end tidal. You can also make it to determine that, yeah, we can work this patient for the next 5 days and we're still not going to bring them back no matter how good we do, because their end tidal is 8. There is no metabolism occurring to go ahead and make that carbon dioxide within the body. The body has completely shut down. You can use it to go ahead and determine someone with COPD or asthma. Someone's got bronchospasms. Do they have that of asthma? I'm going to try and say it again. By the shape of the shark fin. How much are the bronchioles going ahead and spasming or constricting? You can determine if you've got, maybe a problem with your tube. Someone is getting ready, like especially in peds, when they're doing this stair stepping on the back side here, phase 4 of it, they're getting tired. Probably a good idea to go ahead and get your intubation equipment out and get ready to ventilate. So be using it for a lot of different things. If you're unsuccessful, we are going to then go to our rescue airway. Currently, we are using the King in our system. We are going to be starting, and I talked to Chief Pollock May 1st, we are going to be doing a pilot program on the iGel. The iGel is an airway that looks very similar to an LMA, but around the area that goes by the trachea, it's a gel and it kind of forms and molds to that airway. So in this next month, we'll be coming out doing some training sessions with you guys on how to insert it. It's really very, very easy, how to secure it. And then there's just going to be one piece of paper with a couple questions for you to go ahead and fill out for QA. Honestly, I know Lake Forest Hospital, they said they're doing the iGel. They're going to that. They're not even going to put the King tube out there. The reason why a lot of times that most people are starting to go away from the King is the same thing with the Combi tube. That balloon in the back of the oral pharynx gets a lot of times so overly inflated that it's decreasing blood flow back to the brain. And so they're trying to get rid of it, trying to move to something that's not going to be bad. It doesn't cause tissue necrosis in the back of the throat because of the fact that that balloon isn't so overly. Yes, did you have a question, Becky?
Yeah, if we're moving to this, are you guys providing those iGels in?
Yes.
I know last we talked to you.
Yep, I was able to get them.
Okay.
We had, at our educator meeting Wednesday, Drew came out, the rep, and he brought iGels. I have one set for each one of your ambulances. and then I place another order to be able to restock them. We're gonna try and do this for 6 months. And so the company has replaced or given us, and then I'm gonna try and get St. Francis to go ahead and get us some more. So I've already placed the order, and it looked like yesterday afternoon it had actually gone through. And we'll get you some more of those if necessary to go ahead and use. But we really want to see the pilot program first. When we decided to do the pilot program, I decided this in January. Dr. E is really wanting our system to kind of like be the leaders, doing some of these pilot programs, looking at new equipment, looking at new ways to do things that's going to be better for our patients. Now, when I talked to Diane Newbecker up at Lake Forest, their system coordinator, she's like, our doc says we're going to it. When we had our protocol meeting, Condell Highland Park Vista says, hey, I thought we were all supposed to play nicely together. And we said, well, we'll provide the data to show you that should we or should we not switch to the iGel as a region. A lot of places around us are switching to it as their rescue device. So I don't see it not happening in the next year, to be very honest with you. So we'll be doing that over the next month. I'll be doing some train the trainers here at the department, and we'll get those on the ambulances and get the forms that you're going to need. And I think that Chief Polyp asked if it was a digital form so that he could put it right on the computers to make things so you don't even have to carry paperwork around. So, let's see here. The problem with supraglottic airway devices, though, is that if you have a patient, you really need to have that intubation. Someone who has a burned airway, superheated air, maybe some chemicals, someone that is going through anaphylaxis. That airway closes, you're not going to get a tube to pass it if you wait too long. That's why it's really important for you guys to be aggressive. You know, we keep talking about the firefighter from Chicago that died a couple years ago from inhalation from heated air or for fire. And, you know, we talked to the Chicago providers and like, I had nothing. I had no way to knock him down and intubate him. And by the time they got him into the ER shortly after that, very quickly his throat closed up. He was sitting there talking. And how scary is it to have a patient in the back of your ambulance that you're having a conversation with, and all of a sudden go ahead and say, this is what I'm going to do. I'm going to give you some medication, and then we're going to put a tube down your throat. Most people feel very uncomfortable doing that, but really it needs to be done. You need to make sure you're securing that airway early. And it's the same thing when you're dealing with anaphylaxis. You've got someone, their airway is really starting to close up. Get it done early, because otherwise you're going to end up with another type of skill, and that's going to be your quick trach. And we don't want to go that far if we don't have to. Other airways, surgical airways. Again, we have surgical crikes, we have quick trachs. We use quick trachs here, and we use them on anybody over 76 pounds. That's our 4.0. From 22 pounds to 76 pounds is our 2.0 quick trachs. Anybody under 22 pounds, we go back to using the needle crike for. But it is a way to secure the airway. So we start taking a look at different respiratory disorders. Bottom line, if a person is having problems breathing, we don't ever want to deny them oxygen. But you do have to remember, oxygen is a drug. It's not like 10 years ago where everybody got a non-rebreather of oxygen at 15 liters. We found out that it can do damage. It can interact with medications that we go ahead and give. We know that giving oxygen to stroke victims is not a good thing. They're actually using it as fail points on like the National Registry. If you give a stroke patient that doesn't have a low oximetry reading oxygen, it's an automatic fail. You know, they're that serious that we don't want to give people oxygen if we don't have to. As far as the goal for a COPD for 96, that's really high. I mean, that's like shooting for the moon. You're probably not going to have that. I would be very happy if I had a COPD patient and they were really at 92, 93, you know, at that point, but that's really shooting for the stars. We want to make sure too that when we're assessing someone with airway, we got to figure out why are they having the problems breathing that they're having. Is it a real true ventilation problem? Is it a perfusion problem? Or is it something that we have that could be both? So we start with our obstruction for upper airways. Yes, the tongue is the most common reason. You've got older people or our elderly patients who have problems swallowing, and they're eating whole foods and they're not getting it chewed up like they should. And that problem swallowing just increases the likelihood that they're going to choke. You have you guys, you're out Friday night, Saturday night, you're partying, you've had quite a few drinks, you're having prime rib for dinner, and you bite off that big piece of steak and you're chewing it and you're chewing it and you try and swallow and it just kind of gets bigger as you chew it and you get, you have an obstruction. So if a patient isn't moving air, if they're conscious, we're doing the abdominal thrust, which is in past known as the Heimlich maneuver. We're not using those terms anymore. If someone goes unconscious and then we know that they have that obstruction, we're going to CPR. We're checking the mouth, right before we go ahead and ventilate to go ahead and see if there's something there that we can pull out. Other types of obstruction, we have laryngeal edema. Someone who has a near drowning experience with the laryngospasms. Someone who's come in contact with superheated air and that airway is starting to swell. Someone with anaphylaxis. Getting those airways secured as soon as possible. Getting the medication that they need to be or have on board as soon as possible. So if we have someone with anaphylaxis, secure the airways first. Second is giving them the epi. Epi is what they really need to go ahead and help do some vasoconstricting for pressure, helps reduce a little bit of inflammation. We currently give epi-IM, 0.5 milligrams. Okay, we don't give epi sub-Q anymore. Remember, we removed that from the protocols. We also have in our protocols that you can give IV, epi 1 to 10, but you have to contact medical control first in order to be able to give it. After that's on board, you've got your next drugs, you've got your Benadryl. Don't forget about your inline innovations if you need to bag in an albuterol neb treatment for them. With our other, mainly we see this a lot of times with pediatric patients, croup and epiglottitis. Do not discount adults though for epiglottitis. We have been seeing cases where adults are suffering from epiglottitis. Maybe they have not been vaccinated. Maybe their vaccination needs, a booster. For croup patients, we see this being kids under the age of 5. It's very common for this to be you guys getting a call in the middle of the night. Usually in the winter months we see mostly. They have that, mom will give you the history that they've been sick for the last couple days, maybe haven't been feeling the best. Low-grade fever, nice seal bark type cough or barky, hacky cough. You get them out to the back of your ambulance, just gave your report, you turn around and the kid's no problems, he's perfectly fine. Because that cool air has now helped, which is why they tell parents, wrap everybody up in blankets, go sit outside in the cold air, or fill the bathroom with superheated steam to help with the moisture, to help reduce the inflammation in the airway. If you have a patient with epiglottitis, these patients look sick. For kids, keep them as calm as possible. You don't want them starting to cry or getting agitated. If they're perfectly fine sitting on mom's lap and that's where they're the calmest, you take them away from mom, they start fussing, put mom on your cot. Let her, put the child between her legs and take the child in if they're small into the hospital, but keep them relaxed as possible. If they get agitated, that throat can close up with no problems. Usually age 2 to 6, these are the sick kids. They're drooling. They've got a little bit higher of a fever. They're sitting bolt upright, but they're not coughing. If you remember our protocols, both of these start to say with humidified oxygen. That would be going ahead and using your nebulizer setup, putting some saline in it, and humidifying the oxygen that they go ahead and breathe. If it becomes a problem, you can go ahead and nebulize the epi. But remember, we have that chart along the bottom that talks about the different concentrations. So and it's based on age. So the lowest weight, I think that's under 10 kilos, and I don't quote me because I can't really remember what the weights were, but you're mixing 1 ml or 1 milligram of epi with 4 mLs of normal saline and nebulizing it. Till you get up to the heavier weights, and then it's just 5 mLs of epi 1-to-1, or 5 milligrams, and you're nebulizing. So make sure you're looking at your chart before you go ahead and nebulize your epi for these patients. Patients who have infections, pneumonia being a big one, can be bacterial, fungal, or viral. How are they going to present to you? Well, they're probably going to say, hey, I haven't been feeling good for the last couple days. Maybe a low-grade fever, productive cough, yellow, green type sputum they're coughing up. Lung sounds, wheezes, could be rhonchi that you're hearing. Heart rate's up there a little bit, respiratory rate's up there. With our pneumonia patients, it's usually unilateral, meaning you're hearing it on one side and not the other. Not saying they can't have it in both lungs. Don't always say too that everybody that has pneumonia has to have a fever, but make sure you're assessing your patients very good. You don't want to go ahead and mistakenly assess and diagnose a pneumonia patient as a COPD patient. Oh, I thought I heard rails, so I gave them Lasix. Because that's going to take and remove some of that fluid from that empyema, that infection, and it leaves it there in the lungs, and it makes it very difficult for that to get out later on. And to help them cure it. It slows down the curing process or healing process for these patients. So make sure you're doing really good assessments. What can we do for someone who has pneumonia though? We pick them up. We don't have a pneumonia protocol. Just take them in BLS. A lot of you may agree. Some of you might say, well, I can start an IV because they're probably dehydrated. I could maybe give them an albuterol neb treatment if they've got wheezes or large bronchi going on. Help bronchodilate, move a little bit of that mucus. Sure, absolutely. You can go ahead and do that for those patients. Patients that are suffering from asthma. So using our capnography is going to be very important because we should see that shark fin or that delayed upstroke on phase 2 for them to go ahead and determine if they have bronchospasms. Depending on your patient, if you take a look at our protocol says give them a duoneb. If that doesn't work, give them another duoneb. If that doesn't work, give them an albuterol treatment. By that time, you finish your report and you're on your way back to your station. You know, if you have a patient who is really suffering, they've taken some of their own neb treatments at home, it's not working, fine, have your partner start the neb treatment, someone get on the phone early, ask medical control, tell them the story, tell them what's going on, tell them very clearly, you know, does my patient have a cardiac history? Are they over the age of 40? Are they tachycardic because of cardiac? Or are they tachycardic because they can't breathe? Explain this. And tell them, I would like to give my patient epi, 0.5 milligrams IM. But make sure you're giving them the whole picture. But try and get that medication on board sooner rather than later. Have they ever been intubated before? If they've been intubated before and they've got status asthmaticus, you're definitely going to want to be aggressive with these patients. Also remember, if they're really suffering, you may in the bases not hear a whole lot of air movement. They could be clamping down so tight that air movement is not occurring. And so getting these medications on board quickly is going to be imperative for them. Yeah, wheezes may be absent. We currently use 2.5 milligrams of albuterol mixed with 0.5 milligrams of Atrovent, and we put it in the handheld neb. If they're too tired, put it on a mask for them. Let them just have it in front of their face. They don't have to even hold it. It makes things a little bit easier for everybody. Get the epi on board. But If you remember back to paramedics when we talk about epi 1 to 1,000, we don't want to give it to patients with cardiac histories. We don't want to give it to patients that are a little bit older. And yes, it still says 40, even though 40 isn't old, but they really want to address the fact of the cardiac history. They want you to address the fact of why are they tachycardic? Are they tachycardic because they can't breathe, or are they tachycardic because they're having too many neb treatments before that, or they have some type of cardiac issue? Patients with COPD, chronic bronchitis. Remember, COPD is that kind of garbage term. A lot of stuff goes underneath it. We have chronic bronchitis. These patients will have that thick, rattly type cough, usually bluish in color, dusky in color, barrel chest. Air is getting trapped inside. They have a problem getting it out. Your pulse oximetry readings are going to be lower, 88 to 90, not uncommon. How about your emphysema patients? You're having problems with elasticity of the lungs. We call these the pink puffers. They have the pink or pursed lips. They're trying to create their own PEEP to keep those alveoli open. Both of these patients, you've got them in the back of your ambulance. What are you going to do with them? BLS? Well, if they're older, you could start an IV. They probably are a little bit dehydrated. Again, you can use your duo-neb treatments if you feel that they're having that much difficulty breathing. You want to bronchodilate. You want to help move some of that mucus. CHF. You get a call at 5:30 in the morning for a 67-year-old male who's having difficulty breathing. You walk in the door and he's sitting on the edge of the bed. And you can literally hear him gurgling from across the room. What's his history? Does he have a respiratory history? Does he have a cardiac history? When you listen to lung sounds, he's got wheezes up above, rales in the bases. You're like, oh, wheezes, albuterol. Those patients you don't want to go ahead and give albuterol to. Their heart's already failing. They're in heart failure. Blood pressure is skyrocketed. You want to go ahead and nitro, CPAP for these patients. Giving them albuterol can go ahead and cause tachycardia on a heart that's already failing. Now, there are a lot of studies that albuterol is given to heart failure patients, but we're just kind of sticking away from it for pre-hospital. We still have Lasix in the back of in our protocol book for our CHF patients. But remember, it takes a while for Lasix to use. The other thing to think about when using Lasix is, if I have an elderly patient, they probably have very poor intake. They're probably a little bit dehydrated. And that's the last thing we want to go ahead and do is give them Lasix if they're already dehydrated. Most of these patients will fare fairly well in the beginning or for pre-hospital if you're giving them multiple nitro. So set them up in the bedroom. Give them that nitro. Put the CPAP on them. Get them out to the ambulance. It's probably been 5 minutes. Quick vital signs. They're probably ready for another nitro. Give them that nitro. Get to the hospital. We're pulling in. Quick set of blood pressure. Blood pressure's still good. Give them one more nitro before you walk in the door. Try and get those 3 nitro on board. Be nice, honestly, if our protocols allowed us in heart failure patients with high blood pressure to give even more nitro. And that's, I know that we have a couple systems that are, systems within our region that are really fighting for that ability. But assess your patients. Do what you feel is best for them. Get the medications on board. Adult respiratory distress syndrome. This is where you start to have fluid going into that interstitial space. Someone who's had pneumonia, someone who has been on a ventilator, someone who's been intubated for a long period of time. Making sure that we're adequately ventilating them. Positive pressure ventilation is what's needed. The difference between a simple pneumothorax and a tension pneumothorax. That's all breaks down to blood pressure. Very tall, thin young men, it's not uncommon for them to have a spontaneous pneumo. They may complain of sudden onset of shortness of breath. They may have pain in one side. Going ahead and providing oxygen to them. Supportive care. You've got someone who does have a tension pneumothorax. You know, what's their blood pressure? Do I have JVD? And then obviously the really late sign, do we have a shift in the trachea? Positive pressure ventilation can be detrimental to these patients. We want to make sure that we're getting a needle decompression done between that second, third intercostal space. Right over the top of the rib. Underneath, you have a lot of vessels, you have a lot of nerves. Stay away from that area. Reassess. We don't put flapper valves on them, we don't put tips of gloves on them anymore, we just leave them open. They close off, you can move either way to the side and go ahead and do it again if necessary. Make sure you're using the proper needle form. We actually are restocking the IV catheters, the 14 gauge with the long catheter on them, the 2.5 catheter. Hyperventilation syndrome. You have someone who is just hysterical. They start hyperventilating. No, we can't give them a paper bag. No, we're not supposed to go ahead and put a non-rebreather on them and only put it at 2 liters, even though that a lot of times that works perfectly fine. We're supposed to use calming techniques. Try and talk them down, you know? Yeah, bag over the. Have them breathe with you. Take a deep breath in, now hold it. If it's bad enough and they're getting the carpal pedal spasms of the hand where their hands start to contract, it can be a very bad thing. And if you've got someone with such high anxiety and you can't calm them down, we do have chemical restraints that we can use for extremely anxious patient. A little bit of Versed will help. Patients with spinal cord, CNS, respiratory muscle dysfunction. If you have someone who's been involved in and has spinal cord injuries, cervical spines, remember that a lot of times their ventilations may be very shallow or absent depending on what level is being affected. Are they, excuse me, are they adequately breathing if they're breathing real shallow? We talked earlier about what is good tidal volume. You know, if you have someone breathing 12 times a minute with only a tidal volume of 300, that's not going to be as effective as someone who is breathing 16 times with a tidal volume of 450. We want that minute volume to be about 6,000 cc's of air. How about someone who's been taking drugs? Go ahead and have someone breathing 4 times a minute. Needles still in their arm. When do we give Narcan? You guys, we're really using Narcan to go ahead and improve respiratory. You've got someone who's unconscious, you took the needle out of their arm, they got pinpoint pupils, but let's say right now they're breathing effectively. Pulse oximetry is okay. Monitor them, watch them. If you see the decline, then go ahead and push the nitro. Or not nitro, I'm sorry, Narcan. Don't push nitro, Narcan. Just bring them enough for respiratory rate to go up. Most of you don't want to wake them up. You don't want to take away their high. You don't want to have to fight them. You don't want them seizing on you. You don't want them vomiting on you. Just bring them up to the point where you're improving the respiratory rate for them. So taking a look at some of our protocols. So this is our carbon monoxide protocol. Not much of a protocol because it says give 100% oxygen, end of story. That's really what we do for patients who are suffering from carbon monoxide. We have a little chart down here. I think you guys have the Massimo RAD 57s here that you can identify carbon monoxide in patients. No?
We have the clips that go into our video.
Excellent. Okay. See what percentage or what their numbers are for carbon monoxide. This is strictly just informational. To say if I have someone with headache, nausea, maybe some vomiting, dizziness, fatigue, they're probably at about a 29%. Consider where do they need to be transported? Is there anybody else in the home? You get there for someone with flu-like symptoms, and now we see, yes, whole families can end up with the same flu-like symptoms, we get it. But also make sure you're assessing, could it be some carbon monoxide? Where do we take them? Someplace with a hyperbaric chamber. Who has the hyperbaric chambers around here? Lutheran? Does Northwest still have their hyperbaric chamber, you know? Was it Northwest?